The specialty built around the most celebrated moment in a person's life is the second most burned out field in American medicine. By the end of this career, you will have delivered more than 300 babies. You will also have been named in a lawsuit. One patient you are not supposed to lose will die under your care. One decision in the middle of the night will follow you for 30 years. You are 19 years old. On a Tuesday in October, you sit in your dorm room with the medical school application open on your laptop. None of those numbers are on it. Level 1. Medical student. Medical student. Zero pay. $235,000 in debt by graduation. Your OB/GYN clerkship is 6 weeks. 6 weeks to decide whether the rest of your professional life will be spent with your hands inside other people's bodies. The call schedule is 24 hours on, then home for a day, then back. You sleep when the resident sleeps, which is never. The second night of clerkship, 2 in the morning. The patient is on her 4th child. The resident is on the phone with NICU. The head crowns. You are the only person at the foot of the bed. You catch. The weight is unfamiliar. Heavier than the textbook said, slicker. More alive in your hands than you expected. The mother starts to cry before the first cry comes. The father's hands are pressed flat against the wall. You hand the baby up to the nurse, and it is the first time in your life a stranger has trusted you with their child. You decide that night. The audition rotation is the summer of 4th year. You spend a month at a hospital you don't know, sleeping on a friend's floor. Pre-rounds start at 4:30. You leave when the chief leaves. The line between being remembered and being annoying is invisible. You walk it for 30 days. The application is filed in September. You go to 12 interviews. The rank list goes in. You wait. Your high school friend who picked computer science already earns $280,000 and works from home. You are 26 and have never had a paycheck. You will not have one for 2 more years. Match day. Your name flashes on the screen. You match. 99.9% of OB/GYN spots are filled this cycle, a saturation almost no other specialty achieves. 86% of the matched applicants are female. You are not. You are looking around the room and noticing. You don't know yet that the first delivery you caught will be the part of obstetrics you remember at 50. The surgery, the litigation, the moral weight. Those are the parts of the job you will actually do most days. In June, you take the first call. Level 2. Intern. PGY1. Intern. PGY1. $67,000. 4:30 in the morning. You pre-round on 12 postpartum patients before 6. Board sign out is at 6. 2 pagers clipped to your scrubs. One for L&D, one for Code Blue obstetrics, a pair of trauma shears in your back pocket, an N95 you have stopped noticing. Your call schedule is every 3rd night, sometimes every 4th. The ACGME limit is 24 hours plus 4 for sign-out and education. The cap runs on a 4-week rolling average. The 4-week rolling average is how the program is allowed to put you on a 110-hour week. The next 3 weeks are supposed to be quieter. They usually aren't. You earn $67,000 a year. Divided by your real hours, that is between $16 and $18 an hour. The bedside nurse you sign out to at 6 in the morning earns more. She reminds you of this once and then never again. The pager goes off in the middle of your sentence. You apologize and walk out. The call is taken in the hallway, and 45 seconds later, you are back at the bedside. The patient does not remember what you were saying. On a Tuesday in October, the floor pages you for a postpartum patient with a fever of 102. The senior is in the operating room. You walk to the bedside, examine the patient, draw labs, and make the call to start broad-spectrum antibiotics. The senior agrees later. The patient gets better. In the call room at 3 in the morning, 2 of the women on your service are eating cold pasta. One of them is 6 months pregnant. One of them lost a pregnancy in November and has not told anyone in the program. The CREOG exam is in February. Your score lands in the 40th percentile. Your program director sees it first. You don't know yet that the pager you carry now will follow you for the next 30 years. It will be taped to your gown in the operating room. It will sit on your nightstand at home. It will travel in your pocket to your daughter's recital, and the weight will not let you forget it. PGY 2 starts in 3 weeks. Level 3, Senior Resident, PGY 3. PGY 3 Senior Resident, $72,000. Night float, 6 in the evening. You take sign out from the day team and the L&D board is yours. 12 to 20 active patients, 2 triage rooms filling. The day attending goes home and the night attending is in the call room across the hall, and every triage call comes through you first. Tonight, 2 beats land back to back. The first one is a hemorrhage. The patient delivers her 4th child without complication, and then the placenta comes and the bleeding does not stop. Uterotonics, 2 units of red cells, by manual compression with your hand inside the uterus and your elbow against the bed. The bleeding does not stop. You call the attending, you make the decision to take her back to the operating room for a hysterectomy at 1 in the morning. Her husband is in the waiting room. He has not been told yet. You tell him. The hysterectomy goes well. The patient survives. You go back to the workroom and stare at a Snickers wrapper for 40 minutes. For the next 48 hours, you replay the moment you decided to call for the operating room. The earlier window, the later window, the paper notes. The literature has named what is happening to you. Second victim phenomenon. The first paper on it was written about OB-GYNs. The second beat lands at 4:30 in the morning. A patient is on the schedule for an induction. 28 weeks. She came in last night for decreased fetal movement. The Doppler hears nothing. You walk into the room. The words are not in a textbook. The husband does not understand the first time. You say them again. The induction will happen on this floor, 3 doors down from a room celebrating a live birth. The Doppler in the next room is audible. You manage the induction over the next 18 hours. The husband does not leave the room. He sleeps for 40 minutes in a chair in the corner. The fetus delivers at sunrise. The mother holds the baby for the first time. You leave the room at 7:30 in the morning. The day team takes over. You drive home. You do not remember the drive. Chief year starts in May. Level 4, Chief Resident, PGY 4. PGY 4 Chief Resident, $75,000. 5:50 in the morning. Alarm. Coffee. The drive to the hospital is 4 minutes if there is no traffic. There is no traffic at 5:50. You round on 3 post-operative patients ready for discharge, review charts, and greet 2 pre-op patients. Boards sign out at 6. 2 surgical cases on the schedule. A D&C at 7, a laparoscopic hysterectomy at 9. Between cases, you call home. Your partner had a baby 9 weeks ago. The phone is on speaker on the locker room bench. You hear the baby for 30 seconds and hang up. You scrub back in for the lap hyst. The pager is now taped to your scrub gown. It rode in your pocket as an intern. Now there is a sterile field between it and your hand. Afternoon clinic. The schedule has a 3rd trimester obstetrics patient, abnormal bleeding, and a fibroid you'll operate on in 2 months. You finish charting at 5:30. The drive home is 12 minutes, dinner is reheated, and you go to sleep at 9. The pager goes off at 1 in the morning, emergency cesarean. You drive back. You scrub in. The baby is out at 1:40. Postpartum bleeding is mild. You go home at 3. You are due back at 5:50. You are also studying for boards. The ABOG written exam is in 11 days. Pass rates are published per program. ABOG sees the numbers before the residents do. You are the person other residents call. The intern logbook signature is yours. The M&M conference next Wednesday is yours to run. The operating room schedule for the junior residents is yours to defend when a caseload slips. Question Bank Week. You stay up until 2 in the morning answering 150 questions. 30 come back wrong. You read the explanations until 4, sleep for 90 minutes, and round at 6. On a Friday in April, a junior resident calls you at 1 in the morning. She had a bad outcome. She is sitting in the workroom and cannot leave. You drive to the hospital and sit with her until 3. You take her shift the next day. You don't know yet that this year is the last year you have a senior physician in the room. The supervision ends at graduation. You pass the written. The oral boards are 2 years away. graduation, then the first call. Level 5, first year attending. First year attending, $300,000 to $550,000 depending on the contract. The first night you take call alone, the supervising attending is gone. Pages route to you and stop there. The fork shows up before your first month is over. Private practice partnership tops out at $550,000 a year if you make partner. Academic generalists earn closer to $250,000. The middle is hospital employment with RVU bonuses or laborious shift work. Fewer dollars in exchange for predictable shifts and no call from your own bed. How long you keep doing obstetrics is the real fork. Your first weeks are texture you were not warned about. You fight for months for operating room locker room access. The older partner's lockers were assigned 30 years ago and the room is at capacity. EHR access for fetal monitoring is denied for 2 weeks because of a paperwork delay. You write the fetal heart rate strip notes by hand on green chart paper. Lunch in the doctor's lounge is quick, quiet, and alone. Older physicians eat at separate tables. A senior in your group has been in practice for 26 years. She has never been sued. Her malpractice premium is $110,000 a year. She tries to switch to a self-funded litigation reserve permitted under state law. The hospital does not accept the structure. She is at Disney World with her grandkids when her phone rings. The hospital's CEO leaves her a voicemail. Her privileges are suspended. The family relocates. Her daughter applies to internal medicine. The first plaintiff's letter arrives in your 5th year. The obstetrics statute of limitations runs 27 years. Birth injury claims can be filed until the child reaches majority. Every chart note is now a legal document. Your pager, your phone now, rings from your bedside. It used to ring from inside the hospital. The call now comes from home. 5 years pass. Level 6, subspecialty attending. Subspecialty attending, $400,000 to $820,000. At the end of PGY3, you decide. You rank your fellowships. You match into gynecologic oncology. The next 3 years pay fellow stipends while your residency cohort earns generalist salaries. The opportunity cost is roughly $800,000 in foregone income. You relocate. Your partner leaves a job they liked. Your first radical hysterectomy as primary fellow takes the entire afternoon. The patient is 38. You take the uterus, the cervix, and the surrounding tissue. The whole specimen comes out as one piece. The pathology will come back in 72 hours. She wakes up in recovery and asks if she can still have children. You sit down on the rolling stool and have the conversation you were not taught in any rotation. The answer is no. Her oncologist will discuss surrogacy. You hold her hand for 30 seconds. You move to the next patient. 8-hour cases come later. Ovarian cancer cytoreduction involves bowel resection, splenectomy, diaphragmatic stripping. You stand for the entire operation. Your back stops working in your 40s. You learn to inject your own trapezius. Your post-op rounds include telling Mrs. Lee that her CA-125 is back up. Her cancer has returned. You have known her for 2 years. You will know her for 2 more if she is lucky. The other forks of your cohort branched at the same time. Maternal fetal medicine, the bad news specialty. The work is severe preeclampsia at 26 weeks, twin-to-twin transfusion syndrome, placenta accreta delivery teams. Wins are 5-year wins. Reproductive endocrinology and infertility. Egg retrievals at 6 in the morning on a Saturday because biology does not respect the calendar. Patients pay out of pocket. They grieve out loud when cycles fail. Top decile compensation in private practice exceeds $820,000 a year. Female pelvic medicine and reconstructive surgery, sacrocolpopexy, sling, fistula repair, the longest uninterrupted operating room time of any subspecialty. The patients whose names you will still remember at 60 are the ones you saw this year. Some of them will outlive their CA-125 readings. Some will not. You will carry both lists for the rest of your career. 15 years in. Level 7, Department Chair. Senior Partner, Division Chief, Department Chair, $600,000 to $1.2 million. 25 years in, you stop delivering babies the year you turn 52. The reasons cluster around 50 to 70% malpractice savings, predictable sleep, and the end of being on call from your own bed. 30% of OBGYNs make the same decision within 12 years of starting practice. You move into department leadership 3 years later. The work changes shape. Hiring committees, ACGME review boards, M&M leadership, donor lunches. You keep one clinic afternoon a week so you remain board eligible. The microphone you now have is louder than any you held as an attending. The 70-hour weeks are different. They happen at desks. Your income flattens. You earn what a senior partner earns and a third less than the surgical chair down the hall. A colleague you trained with relocates from Idaho to Minnesota. She tells the AAMC she left because the law prevented her from helping a patient sitting in her own clinic. The ACOG president names what she is feeling. Moral injury. The word arrives at the top of the field's microphone for the first time in your career. Your pager, the same pager in shape and size, sits in your jacket pocket at your grandchild's piano recital. It is no longer L&D. It is a colleague in Idaho asking how to manage a ruptured ectopic under a state law constraint. You step into the lobby and answer the call. You walk back in for the second movement. The chair across the hall, the gynecologic oncology chief, the one who chose cervical cancer surgery 30 years ago, has been at the same hospital for the entire span. She still operates. She has not made the drop obstetrics decision because she never started obstetrics. You sit in your office at 6 in the evening. The schedule for next week is on your screen. You have one operating room case, 3 committee meetings, and a recruitment dinner Thursday. You think about the radical hysterectomy you watched as a medical student. You can still feel it in your hands. The hospital is the same hospital. The L&D unit has been renovated twice in your career. New floors, new monitors, new badges. The room you delivered your first baby in is now triage room 4, the room next door, where you inducted a 28-week demise as a senior resident, is a postpartum suite. Babies cry in it most nights. You walk past triage 4 on your way to the chair's office. The room is in use. You do not stop walking. In your office, you sign a budget. The phone rings. Idaho, calling about a patient. You answer the call and walk to the parking garage. Your knees hurt. The pager that became a phone is in your pocket, and the screen is lit. Somewhere in this hospital tonight, a husband has pressed his hands flat against a wall. Somewhere, a placenta has been delivered. Somewhere, the bleeding will not stop without 2 units of red cells. Somewhere, a Doppler has gone silent in a room 3 doors down from a live birth. You can still smell the first one from here.